So whenever the bladder is full, completely distended, it is less than 3 millimeters. Larry got me all distracted. I can't say myself now.
Oh, yeah.
Okay, and then if it is empty or partially distended, then it needs to be less than 5 millimeters. Okay. Number 3, when performing a renal ultrasound, the kidneys and blank should be evaluated.
Bladder.
The bladder.
The urine.
The bladder. Like uterus. Because remember we talked about, like, if there's hydronephrosis or something, or some kind of obstruction, you want to look in the bladder too. Normally you don't see ureters unless there's obstruction, so you can, if there's some kind of obstruction causing the ureters to be dilated, you can see the ureters then, but always check that bladder as well.
Because I was just thinking, like, you would check, then come down to kidney, to the ureter, to bladder. Okay.
Oh, no.
Does uterus not count?
Uterus don't count.
I thought it was the same thing.
No,
guys don't have.
You can evaluate strictly leaving out all these things.
The renal and the uterus were connect, or if something was wrong in
Yeah, I said ureter.
I may let yours count. Like, you got pelvic. Look, you put pelvic. I might have to give her that one. Pelvic or yours. Something close. Bladder? Oh, we do have a bladder. Look you and Emily. Okay,
That's all I got, right?
number 4, why is the neonatal uterus prominent and thickened with a brightly echogenic endometrial lining?
maternal hormones.
That's what I put. I put about plus, I said it was kind of wrong.
What was the answer?
Maternal hormones.
Okay, good.
How did you got that right? Okay, right. Okay, the fundus to cervix ratio of a newborn female is 1 to 2.
Oh.
Remember, it'll look teardrop because the cervix is bigger than the fundus, and that's in the very beginning, and then it'll even out to 1 to 1, and then it becomes like 3 to 1 post puberty.
So check 1 to 1. I don't think I put my name on that.
So it's 2 to 1 wrong?
Yeah, it was 1 to 2.
It's 1 to 2, not 2 to 1.
Is this yours?
Well, at least you had the right numbers.
I put that 2 down.
Okay, the uterine arteries are branches of the,
Internal.
and what is the alternative name for that? Hypogastric artery.
Dang it!
I said hippopotamus, guys. You should have got it. Jaleesa got it.
I have something else.
You literally wrote something else.
Alright, number 8, the blank caused a bright central echo within the tubular vagina. Mucosal wall.
Mucosal wall.
I think I got
I
one
put
right.
mitochondria.
That's the mucosal
Oh,
wall.
I got the one she gave me.
Alright, number 9, the ovary is supplied with oxygenated blood from the blank and blank.
Aorta and the uterine artery. Uterine artery.
Uterus and,
Oh, aorta.
I think it's aorta.
Supposed to be ovarian arteries and uterine arteries.
That's what I said.
But it has your aorta.
I said aorta for the other one.
Okay, I guess the arteries all eventually come off the aorta. So, and technically, but heart, right?
It says we originates directly from aorta.
Yeah, it's right here. Page
And,
726.
Yeah. I'm gonna give it to you, guys. Okay. Alright, the ovarian artery does come directly off of the aorta. Ovarian artery is more correct, but aorta is right too. Just everything has to come off the aorta. So, okay. We'll have to look at these after class.
Throw that curve in.
Well, that was our first clue in the building.
Julissa, we said that last one.
Yeah, I know we got fun.
Deja vu.
We here. I think I passed only one.
I did too, the first quiz.
Yeah,
I
okay.
made one and better than I had on one of
Or
them.
what do you smile at your patient?
That was the only one I passed. You let the bed roll down?
We're going to have fun again about 6 years worth of reading.
But I'm done with my work, I don't wanna look at it again.
Yeah, the outline is right over.
Shoot, I have to stay up until 2 o'clock in the morning to be able to even do that.
How late is it?
Yeah, because you guys have a test next week.
What?
It's on the calendar. Has everybody signed in? Almost? Alright, so today, you guys, we've got to finish chapter 22 and cover all of 39. And then you'll have a test on chapter 28 and 39. I've got it mostly made. It'll be 115 questions.
Can we look at?
No, right now.
I like the way you think.
Next week.
And 28 and 39. It's 28 and 39. Just chapters 28 and 39. There'll be 115 questions. It is true, false, and multiple choice.
I'm scared now.
That's a lot of questions.
No, I'm just scared now. Just because that quiz, like, it's just so much, like, I knew the words and stuff, like, even when you were going over the answers, I knew those words, I just haven't been able to relate them yet, I guess, so. Now I'm like,
We need to take one.
or that's what you take from.
Oh.
Hold on, you're right here.
Yeah, that's what's so hard about
Yeah.
Yeah. And I may drop some of the, if everybody got like one question wrong, maybe something.
Okay, so I only got 2 right, so y'all get 8 wrong. So, I know
Okay, Malia, you sign in?
Yes, ma'am.
You sign in? Everybody. Okay, let me make sure my phone is off. Okay.
I was looking at myself.
Look, there's number 1, there's an answer. You post the wall, comes right into the echo.
I
think we talked about technology.
Okay.
Yeah.
Alright, so pathology of the pediatric genital system. We're going to skip down to the second paragraph and just highlight that whole paragraph right there. And that says okay, I showed you guys these pictures.
Here we go again, y'all, just highlight the whole book. I know.
This chapter is not that bad. Next chapter is 39. There's a lot. I guess I don't have a clip for that. Okay. Alright, the uterus provides the endometrial canal for the site of implantation and growth for the intrauterine pregnancy. So the endometrium is just in the uterus. It's not in the vagina. That's just those mucosal walls that are right there. The endometrium is just in the uterus, and that's where implantation of, for pregnancy, once the egg gets fertilized, the zygote comes down and starts trophoblasting everywhere, it implants into the endometrium. Developmental problems, interference with blood supply, or distortion of the uterine cavity may result in infertility or spontaneous abortion, and that's a miscarriage. Spontaneous abortion is just a miscarriage. And so there's like a lack of blood supply there. If there's like fibroid, the distortion of the uterine cavity, if there's a fibroid that pushes up on the endometrium, and where the endometrium, you won't see it kind of going up like this, it'll be kind of wampus looking like that. That can cause infertility issues. Alright, congenital uterine abnormalities occur in approximately 0.5% of females and are associated with an increased incidence of abortion and other obstetric complications later in life. It depends on the kind of congenital uterine anomaly, and we're going to go over every over every single one of those. Certain ones have a higher infertility rate than others. Like a septate uterus, that has the highest rate of infertility, whereas a bicornuate uterus, you can still get pregnant just fine. But there are 0.5% of females have this congenital abnormality. Look at the next paragraph. The next paragraph says the uterus and upper third of the vagina are derived from the embryonic Müllerian or paramesonephric ducts. I think a lot of you guys got that right. Müllerian ducts, paramesonephric ducts, it's the same thing. They just have two names. And that was actually a registry question of mine, was the uterus is formed in utero by the Müllerian ducts. So know those two. Okay, move over to sonographic findings. If Müllerian anomalies are encountered, the kidneys should be examined for ipsilateral renal agenesis or morphologic abnormalities. What does ipsilateral mean? Same side. Same side as ipsilateral. Contralateral is the opposite side. So saying it would be like spleen and right kidney. Those are contralateral. But with uterine anomalies, these congenital uterine anomalies, congenital renal anomalies can also occur, like the renal agenesis. We had a patient, we just had a student, she had a bicornuate uterus and a duplex collecting system. And that's because in utero, like when she was an embryo, the urinary system and the reproductive system all form from the urogenital ridge. It's just this one little thing that just forms the urinary system and the reproductive system. So that's why if you have a congenital abnormality in one, you may have it in the other. Okay? So uterine anomalies, also look at the kidneys. There can be anomalies there too. Okay?
That question. I missed that. Yeah. Anyway.
Well, maybe I'll give you that now. All right. All right, moving down to Müllerian anomalies. Okay, so I did get past this. Okay, so did everybody get, is there any answers for this one? I'm not sure if there is. No. Are you guys still doing your, yeah, okay. Okay. And then there's the sonographic findings. Again, this is talking about the kidneys. Look to see if there's anything abnormal with the kidneys whenever you see congenital anomaly with the uterus. Okay, here is an example. Here's a uterus, a bicornuate uterus with a pelvic kidney. So that's bicornuate uterus, that's a congenital anomaly as well as a pelvic kidney. Because originally kidneys develop in the pelvis and then they rise up. But if they don't rise up, you have pelvic kidney.
Maybe they just have a transplant.
Maybe, but it says pelvic kidney. Okay. Alright, Müllerian anomalies. These are the different types. You've got the double uterus, double vagina, or this is the didelphys. And then you've got your bicornuate uterus, which this is the wide space cavities. You know, you have two uterine cavities, and you have like a little fundal notch. So it looks like you have two funduses, and then you have two wide spaced endometrial canals. But then you have, one cervix, one vagina. And then you can have the bicornuate uterus with a rudimentary horn, and this is the left horn. You can have it on the right side too. But that's just where you have the two horns, but one of them is rudimentary. It's kind of small, weak, not really all that very functional. Yeah, you can get pregnant. If you have one of these, you can get pregnant in the rudimentary horn, but chances are, it's not really going to make it as a high infertility rate with that. Or a spontaneous abortion, like the pregnancy will usually last up like 8 or 10 weeks or something, and then usually you spontaneously abort. A septate uterus is kind of like a bicornuate uterus, and where you have two cavities, only they are closely spaced, and there's only one fundus. See, there's no fundal notch here, the way there is in the bicornuate uterus. And then, I'll tell you guys all what to highlight here. I don't know why I'm just going off on my PowerPoint here.
Okay, so, how mine?
We're gonna go over all this again.
Okay,
We're gonna go over it again.
no, just like, what?
Alright, so the unicornuate uterus, you think unicorn, it just has one horn. And it's really small or thin, but it's long and slender. And then you have your arcuate, which is like your T-shaped endometrial canal. It kind of comes up and it's T-shaped. You have a little fundal notch here. Okay. And that's what was your quiz to begin with, was just labeling all of these, but we didn't make it that far.
Oh, well, I put a name here.
I think most everybody felt it last time I did that quiz too. Okay, so let's go back to the book, and then we'll go over all of these again. But downward vaginal atresia is diagnosed. Well, we'll say vaginal atresia. Atresia is where, something just doesn't develop. It's like the absence of it, kind of. And so vaginal atresia means you don't have a vagina.
You don't have one?
You don't have a vagina. And that is diagnosed by the development of hydrocolpos, which is fluid-filled vagina. So hydro, that's fluid. When you see colpos, think vagina. So fluid-filled vagina. Hydrometrocolpus is the fluid-filled vagina and uterus. So whenever you see hydrocolpos and then that metro is thrown in there, you know that it's also going to be fluid in the uterus as well. And then you see hematometrocolpos, that hemato, that's blood. And so that will be blood in the vagina and the uterus. Okay? And that is because it can't go anywhere. It can't come out. So you're going to see that in the vagina and in the uterus. I guess it depends on, it can be seen with an imperfect hymen as well. And we'll go over this more whenever I get to like uterine anomalies. But if like the lower portion of the vagina doesn't develop, then you can still see some of it in the proximal portion of it. So, because you can either have like complete absence of the vagina, or you can just have like the imperfect hymen, which is where it's almost kind of like there's like a skin over the vagina where nothing can come out.
So you can't have menstrual cycles.
And that's usually when it's found, is when, and I have a picture that's pretty gross. Can you see it? Here, I'll show it to you guys.
I couldn't
I think it's this one.
No, but I mean, like,
Yeah, that's it.
That's one?
Yeah, that's an imperfect hymen. Like this is vagina here. See the labia minora and the minora
it kind
there?
of formed
It
with
don't
the
have an
end.
opening.
Yeah, nothing like, I mean, you couldn't put like a tampon in there. She couldn't have sexual intercourse. Because that is, I mean, if you want to have a pap smear or something, it's just that, and that's retained, this is that hematocolpus. So this is blood just in the vagina. But if it's hepatometrocolpus, it would be in the uterus as well. But this is just blood in the vagina.
Can I ask a question though?
Uh-huh.
Okay, see how like the blood part is, does it not, like, do they have menstrual cycles and it backs up, like builds up?
That's what it is. This is a female who has just reached puberty,
Oh.
and she's having her menstrual cycle, but it can't go anywhere. So you see all this blood just sitting there and doesn't have anywhere to go.
So what they do is they drain it.
Cut that joker open.
So they cut it open and then she has vagina.
Yeah. I mean, she has a vagina. It's just she has an imperfect hymen. So the hymen's just completely shut.
So she would have to have surgery to get it open.
Yeah. And I wonder, they might even do that in the doctor's office. Put some lidocaine on there and just, I don't know how they do that.
Well, they could do like how they did get fluid off the needle.
Yeah.
I mean, like, probably like a gusher.
They just lamp it like a oil or something.
Yeah, because that's how they get fluid off the needle, is that needle.
Okay, back to what we're saying. Why? Always start over.
So we should, I know.
Okay, here we go. Back that, that is failure of the vagina to develop. And then it can be diagnosed again by the hydrocolpos, which is the fluid in the vagina. Hydrometrocolpos is the fluid filled vagina and uterus. Or hematometrocolpos, which is the blood-filled vagina and uterus. And if we just, took out like the uterus part, it'd be hematocolpos, which is just the blood-filled vagina, which you guys just saw. All right. And here is an image of hydrocolpos. Here being bladder, here's U for uterus, because you can see the little uterus here in the endometrial canal. So there's our cervix. This is the vagina right here. That is a lot, that's a lot of fluid in there. It looks painful. Bigger than your uterus. Almost as big as the bladder there.
It would be like the other picture with this.
Yeah, that's the internal though, like where, right?
Yeah, this is the inside. There may be, if the patient has that imperfect hymen, then it would look the same. But if they, they don't have that problem, and maybe they have that vaginal atresia, and it's like the lower portion, and you just can't see inside just yet, then the woman would look normal on the outside, unless they really start digging in there with one of those like, forceps. That's it.
Yeah.
Yeah.
Right?
Yeah. Okay, so here is hydrometrocolpos. So here we've got the fluid in the vagina here, through the cervix, all the way into the uterus. So here's where our endometrium is supposed to be. And here's our cervix. So you guys remember from scanning, you saw vaginal canal come down, and then uterus usually came up a little bit. Unless you're Lauren, or Jessica, you come down here. So this is anteverted, anteflex, and you can see fluid all through the vagina, cervix, up into the uterus. That's hydrometrocolpos. Okay? And then hematometrocolpos, I'm going to turn the light on so you guys can see. Blood looks different than fluid because there's like internal echoes. So you see the difference here. If that was just straight black, like how it was like in here and there, even though that's fluid, but this is blood. And if you guys were, I don't know if we went over this, but very fresh blood looks anechoic. That's very, very fresh. But the older it gets, the more echogenic it gets. So if this was like a very, 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 very fresh bleed, it could be anechoic. But this has aged a little bit. It could be a day or two old, if not more. And that is a lot of hematometrocolpos. And so you can see it all here in the uterus and it going into the vagina here too. Okay? All right. Moving on to uniformate uterus. It is related to infertility and pregnancy loss. So the uniformate uterus is a congenital anomaly that is related to infertility. There is a higher rate of infertility when a woman has a uniformate uterus. Sonography demonstrates a uterus that is long and slender. It's like cigar-shaped and deviated to one side. And then usually renal agenesis is apparent on the contralateral side. So this is something kind of specific to a uniformate uterus. If you've got your uniformate uterus and it kind of deviates to the right side, then you're not going to have your left kidney. But if it deviates to the left, you won't have your right kidney. So it's that contralateral renal agenesis whenever you have a uniformate uterus. Okay. Let's move down to uterus didelphys. Big side where it hang on. Uterus didelphys is a complete duplication of the uterus. Okay, I see what I've done now. I don't know what I did with stuff. Okay, so this is, so I added in, sonographic images of the anomalies. This is a unicornuate uterus. It's kind of hard to tell a unicornuate uterus because it'll look long and slender and deviated to one side, but you can move your probe to one side and make it look normal. Because this almost looks, like a normal, like retroverted uterus. Because this is a transvaginal ultrasound. So on transvaginal ultrasound, retroverted uterus goes the other way. But you can maneuver your probe and make it look normal. But here's a 3D image, and you can actually see it deviating to the patient's left side here. Okay, now uterus didelphys. And that is a complete duplication of the uterus, cervix, and vagina. This condition is not usually associated with fertility problems and does not generally require treatment. Everything is usually fully functioning. However, you know, one uterus is usually a bit smaller than the other, and whenever, you know, a woman has the uterus didelphys, then you go to like their gynecologist, kind of see which uterus is bigger and could look healthier, and then they can know to have intercourse through like that vagina to make sure that they would get pregnant in that uterus.
That's the wrong one.
They're probably back to back. There's probably a variation in who, like a case to case. I don't know their side by. I didn't know that was possible.
That's too wild.
It is, because you know, this stuff is crazy. You guys have big journals and stuff and people's stories, and they'll have this stuff online.
Can we get pregnant in both at the same time?
You can.
Here's a great time.
Yeah, you can get pregnant from both, and it's usually not a problem. You can get pregnant with twins and it be just fine. However, if one of the uteruses is a little more rudimentary than the other, then the one that's in that kind of rudimentary uterus probably won't make it. But if they're two fully functioning, like perfectly healthy uteruses, then or uteri, I don't know.
But what if they
Right. I mean, would that be considered? What if they're trying to come out like, oh my God.
Probably not.
That would be weird.
Yeah, because what if you got pregnant and then 3 months later you got pregnant another uterus?
Yeah, that's what I'm saying.
I don't know.
Okay, but how do they choose which uterus? I mean, which.
Whichever you can, I mean, if you know that you have that issue, you can have ultrasounds and they'll say, okay, well, this one's measuring this, and the endometrium measures this during this cycle, or during this part of your cycle, and then you can kind of figure out which uterus is like healthier or
And
more.
then go have one removed.
Well, I mean, you don't have to. There's nothing.
You can, right?
I mean,
Possible.
I mean, you can. I don't know. I'm like, insurance to pay for that because there's no medical reason for it unless there's like.
Yeah, there is. I want all my kids from one uterus.
Well,
You ain't gotta worry about it.
Yeah, how do you explain that?
I don't know.
Oh,
Okay, let's keep going. Bicornuate uterus. Oh, wait, here's a double uterus. You guys see that pretty good?
Oh, yeah.
So you got one uterus here, and then there's the other one.
Oh, wow.
This is why. Where that is. Hey, in India, everything cool happens in India. Like that. It's on those TLC shows.
Yeah.
Okay, there's another one where the right uterus is here and then the left uterus is over here. Okay, moving on to bicornuate uterus. That is a duplication of the uterus with a common cervix. So you guys remember we have the two uterus, two uteral canals, endometrial canals, and you have the little fundal notch. So you have like two funduses, and you have two wide-spaced canals. And you can usually get pregnant, and you can even get pregnant in both horns and have twins that way. That can happen. But you only have one cervix and one canal. One vagina. Let's see, there's a low incidence of fertility complications and is usually not treated because there's usually not that high of an incidence of infertility, so there's not a need to have it treated surgically. The exception is when one of the horns is rudimentary and non-communicating. So that's if someone keeps getting pregnant and they keep getting pregnant in that rudimentary horn, you can go in and actually have that surgically removed. But other than that, there's not a reason to have it treated.
Can I ask you a quick question on subject that just like, it's on subject. Whenever they have the ectopic pregnancy, where is, like, what is it out, how does it
Where is it? It's usually in the fallopian tube. That's the most common place. Yeah.
But where, yeah, that's what I'm saying, that comes off of.
Yeah, there, very rarely, the zygote can come in and it can implant and like go through the endometrium and get to the myometrium. That's rare. And also, you know, you can have it like out in the annexus somewhere. That's really rare. Most commonly it's going to be in the fallopian tube because that's where fertilization occurs. So that's where most ectopic pregnancies are. Okay, moving on. Here's a bicornuate uterus. Do y'all see that well? Yeah. Alright, so here's a bicornuate uterus in transverse. You can see it really well in transverse because then you can see both canals. And so you see it just kind of looks normal, just two wide-spaced canals there. I say canal, endometrial canal. Alright, so here is an endometrial canal. A bicornuate uterus. You've got the pregnancy here, and then the decidual, like a reaction over in the right, even though there's not a pregnancy there. You've got the gestational sac, but nothing is going on in the other one. It's just due to the hormones, it's having this like reaction, and that's fine.
Okay, so it's gonna say like echogenic until it like.
It doesn't have like that double decidual sign.
No, I mean like when you're have a baby in there.
A baby.
Pregnant.
Yeah, when you're there you go. I don't know why I can't get that out. When you're pregnant, that's like it's just gonna be dark to start out with. Like, are you gonna be able to?
What? A dark? It'll have that bright. It'll have this reaction here.
Okay,
Bright.
I was looking at that.
Yeah, this is
over
the
there.
gestational sac.
Okay, yeah, that's what I was.
So you got a little fluid here, but that's not like a real gestational sac. That's just like a reaction. Okay. Do you see that says septum may be removed? That little bottom down there. Okay. Alright, so moving on to septate uterus. The septate uterus is in which two uterine cavities are closely spaced. So the bicornuate uterus has the wide-spaced cavities. Septate uterus has the closely spaced cavities. And the septate is with one fundus, not two, like with the bicornuate. And sometimes two cervical canals or a vaginal septum. This condition has the highest incidence of fertility problems, and the septum may be hysteroscopically removed. So,
Sister.
what is it? Sisters? Okay. Alright, so with the septate uterus, that has the highest incidence of infertility issues. But you can go in surgically and remove this septum here, and all is well.
Is the infertility problems, or are the infertility problems caused by like closing off?
It's because this little septum here is usually so weak that it can't do anything. It just gives way. You know, you got your endometrial canal, you have an anterior and posterior.
Mm-hmm.
You know, you've got two of those, and you have to have both of them fully functioning. And if one of them's weak, you know, what if the baby implants right here? It's not gonna make it. Or what if the placenta starts to form there? It's just not gonna make it. And because this is usually really weak, and that's why. Okay, moving on. Here is a septate uterus in transverse. Can you guys come see this one? You see the two canals here, one here, and then one there, how closely those are spaced compared to the bicornuate. When we looked at those were like way like out here, and then the septate's right here. Okay, moving on to arcuate. And the arcuate uterus, that is related to the exposure to the drug diethylstilbestrol, or DES, in utero. So you have to be exposed to that. For you to have the arcuate uterus, you have to be a fetus, and your mom had to have taken that DES drug. Okay? And that is a synthetic preparation drug that possesses estrogenic properties. And it was used in the 70s. Everybody seen that Baby Mama movie, the T-shaped cavity? This is what she had. The uterus is normal in size, so you guys move down to the bottom of that. It says the uterus is normal in size and shape externally. However, the cavity is T-shaped with an irregular contour, and it is difficult to diagnose with ultrasound. So, for the most part, everything still looks normal, it's just that the endometrium is T-shaped, okay? And that's your arcuate uterus. Okay. And here is a 3D image of the arcuate uterus and the T-shaped endometrium. So you got your T, it kind of looks like a mermaid tail, kind of.
Ghost.
Okay, I don't see that.
What?
Yeah.
The ghost? Okay, ambiguous genitalia. Errors in sexual development result in ambiguous genitalia or hermaphroditism. That's the same thing. Hermaphroditism and ambiguous genitalia, same thing. True hermaphrodites have both ovarian and testicular tissue. The internal and external genitalia are variable. So one hermaphrodite is going to look different than the other hermaphrodite. The way the external genitalia looks is going to vary from one to the other. Let's see. There is pseudo-hermaphrodites. There's the female pseudo-hermaphrodites. And the most common cause is congenital viralizing adrenal hyperplasia. And that's an issue with the adrenal glands. An increased production of androgen leads to masculinization of the external genitalia. Androgen, that's the male sex hormone that is released from the adrenal glands. So whenever a female is getting too much androgen, because we all have androgen, Larry's got estrogen, we have a small amount of androgen, but whenever there's an abnormal amount for each one of us, we start to, for a woman, we'll start getting like, here it's listed enlarged clitoris, abnormalities of the urogenital sinus, and partial fusion of the labia majora. But also, you may start getting a little hairy, some facial hair, start getting those secondary sexual characteristics of like what a male should have if we have too much androgen in our body. All right, let's see. All right, move over to sonographic findings. Sonography identifying the presence or absence of the uterus, vagina, and ovaries. That's as ultrasound techs, that's what we are looking for whenever we have a patient come to us with ambiguous genitalia. That is to actually be able to find the presence or the absence of ovarian tissue in who, we think is a male. Or this is typically pediatric, in pediatric patients. So one that kind of externally may look like a female, we're checking to see if there's any testicles or tissue like that inside the female. So you can look for those kind of tissues. All right, moving on to, there's that. I don't know, is that an answer on your thing? I should mark it in my books, I know where it's still. Okay. All right, so this is in utero. So here is ambiguous genitalia, specifically it's that clitoromegaly. So you would see this, and would you think like a male or a female? This kind of looks female, but then that kind of looks, male. But that is clitoromegaly. And then here, it's like, well, what is it? Yeah, you don't have that typical turtle shape. There's like no scrotum because this looks female, but then that looks male.
But when the baby's born, do they correct the imperfections?
It depends. I think what a lot of people are doing now is they're waiting to see like what their child identifies as, and then go from there. But I think it just depends on the case and the parents and what's going on. Or if all right, precocious puberty. All right, true precocious puberty, and I was looking at pictures of this online, breaks my heart, oh my gosh. True precocious puberty is always isosexual and involves the development of secondary sexual characteristics and an increase in the size and activity of the gonads. And this meaning isosexual, meaning that, a 3-year-old little girl is going to start looking like a 20-year-old. you know, a 20-year-old female. They're not going to start looking like a male, you know, like with the ambiguous genitalia, it's isosexual. So, you know, little boys, you know, this 4-year-old little boy is going to start, you know, the genitals are going to become enlarged, having, you know, underarm hair. You know, they had this picture of this 3-year-old girl with like boobs like out here. I mean, it was like, it was so sad at the end. I was like, I could not handle my babies looking like that. I'm like, no, these are my babies. They're just babies. Okay. But anyway, so it's isosexual, it's not ambiguous, and so a little girl's going to look like a grown girl, and a little boy's going to look like a man. And that's an increase in the development of those secondary sexual characteristics. So for like a woman, for a female, that's, you know, development of breasts. For a boy, that's like deepening of their voice, facial hair, and also an increase in the size and activity of the gonads. So little boys, their penises are going to get longer, but girl, their boobs are going to get bigger. Or breasts, I guess I should say breasts instead of boobs. All right. The uterus has an enlarged post-pubertal configuration. So for like your 3-year-old who's supposed to have a 1-to-1 fundus to cervix ratio, they're going to have like that 2-to-1 or that 3-to-1 like you see post-puberty. So like everything's just going to start maturing, and they're just going to look like they're 20 or 25, and they're 3 and 4.
Wow.
With an echogenic endometrial canal. So whereas in for like if you're looking at like a regular or not a regular, but a non-precocious 2-year-old, their endometrial canal is going to be like real thin. But if they have this precocious puberty, it'll look thickened, and they'll have the thickened endometrium, and it'll look like someone that has started their cycle. All right, the ovarian volume is enlarged, and that's greater than 1 cubic centimeter, because usually it's about 1 cubic centimeter early, whenever they're young. And then for us, ours is about 3. You know, you've got like 3 centimeters long and width and depth. And there will be functional cysts are often present. And that's what, you know, we all have those functional cysts, because, you know, you ovulate every month, or supposedly every month is what you normally do. But these 2 and 3 and 4-year-olds that have this precocious puberty are ovulating. They're having these like functional cysts. All right, and there's precocious pseudo-puberty, and that involves the maturation of secondary sexual characteristics, but not the gonad. Okay? And in a male, that's the testicles, and a female, that's the ovaries. So those will continue to look normal. You'll just have these secondary issues, like facial hair and things like that.
Are functional cysts like follicles?
Okay. Well, yeah, they'll become larger, and you know they can get up to 2 centimeters. And if they get a little bit bigger than that, they're considered cysts. But they usually just will regress anyway. But yeah, they just are what you ovulate from. Okay. Over to sonographic findings. Is that on here? Yes. Sonography is used to determine the volume and size of the ovaries, uterus, and cervix, and to exclude an ovarian neoplasm. So if we think someone has precocious puberty, we go in there, we have to measure that uterus, measure the ovaries, look at the cervix, all that, make sure that it's in normal size, or if it is enlarged, like this child has you know, sort of puberty or something at the age of 4. But also to make sure that there's not a neoplasm, because they could be getting checked, and you know how the doctor always goes around like this, and they felt something, and they think, oh, well, maybe they have an enlarged uterus, maybe they, you know, have this precocious puberty, or maybe they have a, you know, a big cyst on their ovary or something instead of this precocious puberty. So that's what you also look for. All right. The liver and the adrenal gland should also be assessed in these patients to rule out the presence of a lesion causing the precocious puberty. And that's the adrenal glands. Again, they produce those sex hormones, the estrogen and the androgen, and there are neoplasms, like tumors that can be in the liver that can secrete things like that too. All right, pathology of the pediatric ovary. The typical neonatal and infant ovary is heterogeneous and cystic on ultrasound, and that's due to what? Because of maternal hormones. Most cysts are less than 9 millimeters in diameter. Ovarian cysts develop from ovarian follicles. So these functioning follicles, these functioning cysts, the follicles, they'll grow. And once they hit 2 centimeters, they start being classified as cysts. So ovarian cysts will come from follicles. All right, the difference between a pathologic cyst and a physiologic mature follicle is primarily size. And that is because, again, it's a follicle up until 2 centimeters, and then it becomes a cyst. All right, so skip the next sentence. Let's move down to the primary stimulus is FSH, which is a follicle stimulating hormone. There it kind of says in the name, the follicle stimulating hormone is a hormone that stimulates the follicles. This hormone is secreted by the pituitary gland, specifically the anterior pituitary gland, and it causes the increase in both the number and size of the small follicles. So these follicle stimulating hormones causes these follicles to become stimulated. You're going to get more of them, and they're going to get bigger. And that's just normal for the cycle, throughout the menstrual cycle, which we'll talk about in the next chapter. All right, let's move down to neonatal ovarian cysts. All right, most fetal cysts, let's get that first sentence. Most fetal cysts resolve spontaneously, but they may persist into the neonatal period. Small follicular cysts of 3 to 7 millimeters are a common and normal finding in neonatal ovaries. So if you see them in utero, they typically will just regress on their own, but they can persist once they're born, and that's due to those maternal hormones. And a lot of times they'll just regress and, go away on their own. All right, down to complications. Most ovarian cysts do regress spontaneously, but if they persist, complications may arise. The most common primary complications are hemorrhage and salpingo-torsion, and that is where the fallopian tube gets twisted. Torsion is more common in the larger cysts because it's real heavy. So it's kind of like if you have your ovary, you have a big cyst taken off the side of it, it's eventually going to get too heavy on that side and flip over, and it'll torse. And then clinically, patients present with pain, obviously, and then they may end up vomiting because there is so much pain. You can get fever, abdominal distension, leukocytosis, which is an increase in white blood cells, and peritonitis, which is inflammation of your peritoneum. All right, down to sonographic findings. All right, skip the first sentence. The system may appear to be completely anechoic or have internal echoes if hemorrhage has occurred. So you guys see a simple cyst will be completely anechoic, but if there's blood in there, like how we saw with that hematometrocolpos, either they have that, has the echoes, the blood has the echoes and gets more echogenic and more hyperechoic the older it gets. So if you have a hemorrhagic cyst, there will be echoes in it. It won't be completely anechoic. And then the complicated cysts may contain fluid debris levels. So they'll have the fluid, so you have that anechoic fluid in there, but you also have debris. So you have these echogenic echoes in there. A retracting clot or septa, or it may be completely filled with echoes, producing a solid mass-like appearance. So it's completely filled with, maybe blood, and it's been there for a little while. It may just look like a mass. All right, differential considerations. Sonography is able to characterize the mass, but the diagnosis must be confirmed histologically by a biopsy specimen. That's with a lot of things. A lot of it, like mass, like tumors and masses and different types of cysts like that, you have to have it biopsied and have a pathologist look at it under a microscope and check it out that way to actually say, yes, this is what it is. All right, ovarian torsion. Torsion of the ovary may occur at any age. However, it's most common in the first 2 decades of life. The normal adnexa in young girls may be mobile, allowing torsion at the mesosalpinx, and that is the part of the broad ligament that's around the fallopian tube, and we'll get to that next chapter. And that is with changes in intra-abdominal pressure or body position. So, you know, a 12-year-old will do a cartwheel before a 52-year-old will. So, you know, changes in the body position and things like that can help cause torsion. Torsion occurs more commonly when ovarian cysts. Thank you. Whenever there are ovarian cysts or tumors present, and again, that's like if you have that big cyst or that big tumor hanging off the ovary, it can cause it to flip to one side, you know, kind of make it rotate over, and make the ovary kind of twist on its vascular pedicle, and that's where, you know, the arteries and the veins and all that, it can flip and cut that off and cause torsion. Let's see, this rotation compromises both arterial and venous flow, causing congestion of the ovarian parenchyma and ultimately hemorrhagic infarction. For the ovary, whenever torsion occurs, the ovary will become enlarged and then it'll start necrosing, and the tissue of the ovary will start to die because it's not getting its blood flow. And so you'll start seeing kind of a complicated appearance in there. Clinical symptoms include the severe onset of abdominal pain. So you'll have someone coming in like doubled over like this. Usually it is just a cyst that's ruptured and they're like, oh, I'm dying, and it's usually just a cyst. But occasionally it is ovarian torsion, and that's an emergency. You've got to get them, just like with testicular torsion, you got to get them to the OR and have that thing rotated back. All right, sonographic findings may be non-specific, but may show enlargement of the affected ovary. So again, that ovary will become enlarged, fluid in the cul-de-sac, and other annexal pathologic findings such as cyst or tumor. And that is what has caused the torsion. So if the patient had a big cyst or a big dermoid cyst, and that's what caused the ovary to twist and become torsed, then you will also find that in the annexal area. All right, over to ovarian teratomas. Okay, well, here's a right ovary that is, let me turn this off, please. The torsion is a big thing you guys check for a lot. See, there's no blood flow in this ovary. And this is a transvaginal ultrasound. Whenever you're checking for torsion, if there's an option to do transvaginal, because you get more detail that way. And you don't want to give someone torsion when they don't really have it. See, there's no blood flow here, and they've got this cyst, this big cyst here, and this is probably the cause of the torsion, is it caused the ovary to flip over and have torsion. And you can have complete or partial torsion, because if it was just partially rotated, then, and say like the ovarian artery got cut off, but not like the uterine artery, then the ovary could still, or like right to the ovary, the uterine artery, then the ovary could still have some blood flow in certain areas. Okay? Alright, ovarian teratomas. Let me go ahead and turn this back off. Can you guys see where it says most? Actually, I'm just going to hold it down. Hang on. Is that the only one? Most dermoid tumors range between 5 and 15 centimeters in size. Or put like a rod and a rod. Where are we? Okay, ovarian tumors are uncommon in the neonate and adolescent. When found, germ cell tumors account for 60% of these. The most common pediatric germ cell tumor is the benign mature teratoma or dermoid cyst. It's the same thing. That's the last sentence of that first paragraph. It's a germ cell tumor, and it is benign, and it is a mature teratoma, because there are immature teratomas, and those are usually malignant. And we'll get to those when we do ovary stuff. But another name for a mature teratoma is a dermoid cyst. Alright, benign teratomas have a wide spectrum of sonographic characteristics, and that's because they can be made up of all kinds of different things. And one person's teratoma is going to look different than the other person's teratoma. They have a central cystic cavity filled with sebaceous debris, and that's like, well, like fatty stuff. That is surrounded by a variety of skin appendages, a squamous epithelial layer, and a thick capsule. Other findings may include a solid or complex mass of fat fluid levels, hair fluid levels, and calcification. Again, most dermoid tumors range between 5 and 15 centimeters in size. Clinically, most patients with a dermoid cyst are asymptomatic. It's just going to be an incidental finding that they find this dermoid cyst. But they are typically asymptomatic. When the tumor becomes large, abdominal pain or distension may occur. The most frequent complication of a teratoma is torsion, because the teratoma will be hanging off the ovary and it can cause that torsion. So that is the most common complication of a teratoma, is ovarian torsion. And down under sonographic findings, again, it's a complex mass with a heterogeneous appearance, and there may be acoustic shadowing. These teratomas, these dermoid cysts, they've got a picture of it up in figure 28.1, and it's like the growth pathology of it, so this is actually what it looked like inside the person's body. And there you've got some teeth and some hair in it. It was kind of thought to be, I don't know if this is really true, but it was talking about like if you ate your twin or something in utero. But that's not true. But it'll have hair, it'll have teeth, it can have bone and skin, and just all these things that make you up can be in this cyst. And so that's a teratoma or a dermoid cyst.
Have you seen one of those?
Yes, one. I just saw one, even though how common it was. It was little though. It was little.
Yeah.
Sure,
There aren't any teeth in this one.
I know. Darn, no teeth. Okay, so here is one patient's teratoma. So see, just kind of looks all crazy. It's got complex, heterogeneous, kind of hanging off the leftover there. Just did one. I had more than that. Okay, well, okay, the scrotum. All right, so whenever you're doing a scrotum, you're going to use a high-frequency linear array transducer. That's what you guys use in hemo right now. That's a high-frequency probe. It's going, and whenever you use a high frequency, you are checking for a superficial structure. And the testicles are just underneath that thin layer of that scrotal sac. Their testicles are right there, so you don't need to have this huge curved array that's got to go through, your gut. So you'll use that thin, or that high-frequency linear array probe. All right, skip a few sentences. As in the adult, a small towel may be placed vertically between the legs. So whenever you do an adult or even, an adolescent, you would have them, you would either, I would tell them to always, close their legs like this and kind of pull up the penis and the scrotum and have it just kind of sitting on their thighs like this. Or you can take a towel and roll it up and just stick it between their legs, and the towel will be underneath propping it up. So either way, because that way, yes, Larry?
No.
Larry would have.
I don't have no personal stories.
Oh, I thought you were doing like this.
No. Actually, I wanted to go back to the scrotum should be carefully palpitated to detect. How do you?
We don't palpate. Well, you can. Typically that's already done. The doctor or the nurse will do that. But you'll get in there and you'll have ones. You can palpate it too if they feel if there's like a hard knot somewhere. Usually they come in with just generalized pain. But if they're saying I have a hard spot right here and it's right here, then you palpate it. You'll have to actually put your fingers on the scrotum and then feel where, if it's hard right here, or there's a big knot right there. Or, if it feels real hot or something right here, then you can palpate it. Yeah, you can palpate. And that will help you. And that will help you find wherever it is. If you think that maybe someone has like a hydrocele, you can usually just put the probe down there and just find it. But if you're having trouble just finding it, then you may, can palpate it then. But usually people just don't want to be touched more than they have to be. And they've already been, kind of half groped by the doctor and the nurse, then you can usually just put it down and then find it. But if not, then you can do it yourself and palpate that thing. Be gentle though. Sometimes you want to, whenever you guys start, right now, or maybe not all of you, you want to just do easy pressure. And in abdomen, you gotta push to get that gas out. Don't do that on scrotum, okay? Easy. You don't got gas in there. Be alright, but again, you know, especially once you start getting like the older people, the testicles become more mobile, and so, guys, come on, we can do this. So that's why it's very important to have that towel there, or have their legs closed, because you don't want it like hanging down, you know, on the bed. Come on, guys. You want to immobilize the testicles. So use the towel, close the legs, find a way to do that. And usually you want to have like the penis upwards so you keep the penis covered. I always just told the patients to do that themselves. Just have them kind of fold their penis like upwards and then put a towel over them to cover that. So that's not even to be seen. Okay?
We did it.
I have a really embarrassing story. I don't know if I should tell you guys. Well, you didn't? Okay. I got called in one night, okay, and it was a Hispanic gentleman that did not speak any English. Nobody could speak any English. And nobody was answering the Spanish hotline thing that the hospital had. And so I was like online trying to type in that change the text thing, and I was like, fold your penis on your stomach. And then I wrote it down and I was trying to read it out to him. He's like, what? And then it was like, I mean, midnight. I was tired. I got woke up. I just did it. I just put some gloves on and I just did it. I was like, I'll just do it.
You have little boys.
Huh? Yeah.
Little boys are a little different than me.
I mean, you can't get the point across.
Right. Yeah, it was too late at night. I'd been in the bed asleep. Okay, just move over. I got this. And then what kills me though is that afterwards they'll fix their stuff and then they'll just walk right on out. And it's like, hand sanitizer right there, please, sir. I want to get to where I told them that. Like, that is gross. But I'm like, here, okay. So I'm like, you can clean up, get your stuff, you know, put your pants back on, and the hand sanitizer's right there. And I pointed out, it was like by the door. As you're walking out, it's at the door. So they didn't have no excuse. Get that hand sanitizer. God, it was so surprising how many people did not do that. So I had to start telling them. Yeah, because I mean, and then they get in a wheelchair and they have to put their hands on the rails to sit down. And so everybody's been touching that. I always cleaned the wheelchairs though before, because I saw how many times people was butt naked with their gown wide open. And so I got where I always clean them things. I cleaned the butt, the back, the hands, and then where I had to hold them. I scrubbed with those little PDI wipes, those like green ones that are right there, but they usually have the purple ones. So the purple ones you don't sit 5 minutes. The green ones are 20. But I get those wipes, I clean them things down where I gotta hold those wheelchairs. Okay, moving on. Okay, the sonographer should examine both testes with sonography to compare the volume and echogenicity to one another. So like carotids, you're always going to do both sides. Testicles, you're always going to do both sides. Thyroid, you're always going to do both sides. And that is to compare. And here, like on figure 2814, they've got the testicles all in one image. That's going to be like your first image of a scrotal ultrasound, and also a thyroid ultrasound, because you're going to be comparing the two lobes together all in one image. But also you're going to want to measure the size, because maybe one is measuring, way larger than the other. You want to see which one is, you just want to have something to compare the other to. Alright, embryology, oh, that's still there. So this is just saying that on an obstetric ultrasound, all of you may have already heard this. On an obstetrical ultrasound, the boys, the male genitalia is called a little turtle sign, and then the girls are called the what? You guys have heard that? The hamburger sign?
Yeah, I've only heard the 3 lines.
Yeah, you can have those 3 bright lines, yeah, but then, that's early, but once they start getting old, they're like around 20 weeks or more, they'll look more like a little hamburger. But it's turtle for boy, hamburger for a girl. Alright, normal sonographic appearance of the scrotum. The normal scrotal sac contains 2 testes. that appear homogeneous with low to medium level echogenicity, and you can see that again in that figure 2814. See how smooth and homogeneous those appear? They have like a low to medium grayscale. They're usually spherical or oval in shape with a diameter of 7 to 10 millimeters. The echogenic line of the mediastinum testes and the epididymis are usually not seen in the neonate, but will be seen after puberty. The mediastinum testes, you can kind of see it on the left testicle in that figure, but it's just this like bright white line that you see going across the testicle. And we'll talk about that more when we get to scrotum. But you just don't see that bright white line in early on, or the epididymis. You see that more once they hit puberty. And then we're going to go over all the scrotum stuff all over again in abdomen 2. But after puberty, the testes measures 3 to 5 centimeters in length and 2 to 3 centimeters in depth and width. So, 3 to 5, and then 2 to 3 centimeters. And the tunica albuginea is imaged as a thin echogenic line surrounding the testes. So you guys can see that thin, bright echogenic line that's encircling the testes, the testicle, each one, that bright white line going on, that's the tunica albuginea. There's also tunica albuginea that surrounds the ovaries. So the tunica albuginea surrounds the gonad, which is the testicle in the male, the ovary in the female, and it's just this layer of tissue that just kind of encompasses it and encloses it. All right, the intratesticular vessels may occasionally be seen as a hypoechoic linear band that fills in with color Doppler. So you may actually be able to see intratesticular vessels just in 2D and grayscale without having to turn color on. But if you see something and you think, oh my gosh, that's this or something, you just put color on there, it'll light up with color, and you're good to go. And you know that it's not a cyst. All right, down to the next paragraph. The epididymis is seen along the posterior lateral aspect of the testes. This will help you whenever you're trying to find it. It's on the posterior lateral aspect of the testes. So if this is like the testicle, of course, you guys, this is posterior. So this is going to be posterior lateral. If this is our right. Because here's like midline, because this is our left. Right? So the epididymis is posterior lateral. The epididymal head is triangular in shape and is isoechoic to slightly hyperechoic when compared to the testes. So it's either going to be the same color or slightly brighter. And that's usually what you see most of the time whenever there's not epididymitis. Whenever there's epididymitis, this is going to be real enlarged, it's going to be hard to see, like the body and the tail, but you'll be able to see the head. And you measure the head whenever you do a scrotal ultrasound. And we'll go over all that more in detail in abdomen 2. Alright, there is, very last sentence, there is no visible flow in the epididymis until after puberty. So you check for blood flow in the epididymis. Typically, unless you're working at like children, then you're always just going to check for color in the epididymis. But at children's, I don't know if they check for color, check for epididymitis, but you don't see it regularly, normally, before a male has reached puberty. Okay, cryptorchidism. Oh, there you go. Did you guys need one of those? Was that on your thing, your paper? No? Okay. Okay, so here's another image of the two testicles being compared to each other. This is an image that you guys have to get for scrotal and also thyroid ultrasound. We'll just compare the two. I mean, you're not going to get the testicles in the thyroid ultrasound, but I'm just saying you're going to get the probe right here, and you'll be able to see the two lobes. Okay, so here's the epididymis right here, and it's measured right here. Some people go straight across like that, and some have to, depending on where you are in the protocol for that lab, you can go just straight across like that or go up and down. But there's the epididymis, see that's lateral, and then it's normal. This patient doesn't have epididymitis. This looks like real thin down here. You don't see like a huge chunk of epididymis coming all the way up. Okay, cryptorchidism. Between the 25th and 32nd gestational week, the testes descend via the inguinal canal into the scrotum. So the testicles start in the pelvis, and then around 25 to 32nd week, they descend and go down into the scrotum. The testes should be located within the scrotal sac at birth, sometimes up to 6 weeks. It may take them, if they got sluggish testicles, they may get to the scrotum a little bit late. However, a small percentage of male infants have undescended testicles, and this is where they just don't descend. They stay up in the pelvis, or they stay in the inguinal canal. They don't make it all the way. The testicular descent continues during the first year of life, so that by the end of the first year, only 0.8% of infants have true cryptorchidism. So even if they haven't, even if the testicle hasn't descended to the scrotum by week 6, it can continue to descend throughout that first year. But after that first year, then they have that true cryptorchidism, and they truly have undescended testicles, or undescended testicle, depending on if it's both or one. And let's see, and 10 to 25% of it is bilateral. So most commonly it's just one testicle that remains undescended, but it can be 2. Alright, the malpositioned testes will lie anywhere in the pelvis, although most are found at or below the inguinal canal. So it's like they started their way to the scrotal sac, but didn't quite make it, so they got stuck somewhere in the inguinal canal. The localization of the undescended testes is important because cryptorchidism is associated with increased risk of malignancy. So someone that has the undescended testes, or that cryptorchidism, they have a higher chance of getting testicular cancer. Infertility, they're going to have problems with fertility, and torsion. A undescended testicle has a higher rate of becoming tors. The bilateral absence of testes is anorchidism. If you ever see that like A in front of anything, you know that's going to be like the absence of it. And that orchid, whenever you see that, that's talking about testicle. Like orchitis, that's inflammation of the testicle. And orchidism is the absence of the testicle. So you're not going to have it down into the scrotum. And then you have monoorchidism, and that is the absence of just one. And it is usually the left testicle. I don't know why it's usually the left testicle. It's just if you have monoorchidism, it's usually your left testicle that you're missing. Okay, moving on. Here is, okay, I can't even see that. Alright, here is a testicle that is in the inguinal canal right here. And you have to come up, you're still using a linear probe, but you put the probe like right here, and that's where you would see it. It's right there in your inguinal canal. I had a patient one time. He was like a 13-year-old boy, I forgot what the indication was for, but I put the probe down, saw the testicle, and it went like whoop right back up. And then I was like, where did it go? And I had only been skinny for like a year or 2, and I was like, what is going on here? And he had like yo-yo testicles, and that's where they went up and down. Have you guys heard of that? The yo-yo testicles? Okay, so they'll go down the sac and come right back up. And that's what he had. And then as it turns out, he was extremely underdeveloped for a 13-year-old. So he got sent to children's. I don't ever know what happened after that. But the testicles were really small. Like the penis was really small. You know, everything was extremely underdeveloped. So so it's the opposite of precocious puberty. But yeah, I don't know whatever happened with that. Okay, moving on. Acute scrotal pain. Alright, so the most common causes for acute scrotal pain is testicular torsion, and that can cause the testicle to swell. And if it doesn't become untorsed surgically, it will it'll start to necrose and like atrophy because it's not getting its blood supply, so the testicle is going to die. Epididymitis, with or without orchitis. So epididymitis is inflammation of just the epididymis, with, and then the testicle can be inflamed or cannot, so either one. Torsion of testicular appendages, like the spermatic cord, the extra bells and whistles down there. Testicular trauma, so someone got like kicked there, or you know, I don't know if you have seen those videos of them like skateboarding and doing their bikes on the rails and they fall and they like scissor the so frills. Okay, I misspelled acute. Hydrocele. Actually, I don't think I did that. That might have been the people that did the book. So I think that's true. Okay, an acute hydrocele, and that's just all of a sudden a lot of fluid coming and backing up on that testicle. And then an incarcerated hernia, that's where there's like some bowel has come out and down into the scrotum, and you can't like push it back in, because there's no way to get it pushed back in. And you may have to check for that too whenever a patient comes in and they have like scrotal pain and swelling. You'll have to check to make sure that there's not any bowel in there. Because sometimes whenever you're new and you're first starting, it's like someone has like really bad epididymitis. This actually happened to me. I had just started working too. And we don't do a lot of scrotum here because you have to have volunteers. And so I got called in, of course, the patient had terrible epididymitis. And the doctor was like, well, is there bowel in the scrotum? Oh my God, wait. And I had to think about it, like, how do you tell the difference in bowel? I was like, oh, bowel has peristalsis, duh. And so then I went and I just looked and I was like, no, there's no peristalsis. Okay, that is minus. So if someone has a hernia like that, bowel can get in there. And that's how you would check peristalsis. Check to see that churning. When you guys were doing abdomen, did you see whenever you were looking at the pancreas, you saw like the little black and the little bubbles? That's the duodenum. And that's peristalsis in there. Okay, testicular torsion and epididymitis. Testicular torsion, that is a medical emergency. That's where, just like with ovarian torsion, the testicle is going to rotate and flip on itself. And you're not going, and it's going to lose its blood flow. And you have to get that back rotated by within 6 hours of the actual torsion, or else they can lose their testicle. An important thing with torsion is that whenever you're looking at a torsed testicle, there's no blood flow. But with epididymitis, there's increased blood flow because there's inflammation. Same thing with orchitis, there'll be increased blood flow. All right. With intermittent or incomplete torsion, there may present a varying pattern of flow. So if the testicle is just like partially torsed, then depending on the degree of that, there may appear to be slightly normal, maybe just a little less, or they may have just a little bit of flow, depending on how torsed it is. Okay, sonographic findings may show testes to be normal in echogenicity early, but after that 4 to 6 hours, it can start to swell, and you'll get that edema, and you'll really get those signs of torsion. But you want to catch it within that 4 to 6 hours. So that's where checking that blood flow is important. You got to put the color Doppler on there. And then after 24 hours, testes become heterogeneous, secondary to hemorrhage and infarction, because they're not getting their blood, so they're going to bleed out, and they're going to have an infarction. Okay. Scrotal masses. Okay, so here you can see, here is a normal testicle here. Here is a torsed testicle. See, there is no blood flow in there, and it is enlarged. So that is a torsed testicle. See that image? You always want to get this image. Very important image. All right, and here it is again. Here, actually not again, but this is actually epididymitis. So you've got increased blood flow here. All right, and with scrotal masses, sonography is able to distinguish if they are intratesticular or extratesticular. So we'll actually be able to tell, is this like inside the testicle, or is it outside the testicle but inside the scrotal sac? And this is important because intratesticular masses are malignant, extratesticular masses are benign. That's why it's very important. If you see a mass, you need to be able to tell if it's intra or extra testicular. Okay? Intra bad, extra good. Okay? And then 80% of testicular tumors are malignant. That's why it's just, you see intratesticular, automatically you're going to assume malignant. Same thing with like renal masses. Most of the time, they're cancer, they're malignant, so you see intratesticular masses, consider them malignant. Okay, let's move on really quick to chapter 39. And this is a lot. Oh my God. Anybody want to stay for tutoring today?
Is it chapter 20?
Yeah. I said 29 or 39?
Oh, 39.
I don't have that book. Can we go on the break right quick so I can go get my book?
You can go get your book right now. Is it out in your car? Yeah, you can go get it. But we're still gonna cover the guest. Yep, 20 minutes. We got it. We're gonna try. I'm probably gonna skip a good bit, 'cause I've already made the test. I'm gonna try and hit things where the test is. I will. It's not up there yet, but I will. Yeah. If you guys stay for tutor, we'll go over chapter 39, some more. But hopefully we're gonna try and go over a good bit. Alright, so you guys know there are two ways to look at the female pelvis, the transabdominal and the transvaginal. 39. So with a transabdominal ultrasound, you guys know you have to have a full bladder. With transvaginal, you need an empty bladder. And these are all pelvic the external landmarks for a female, for the female genitalia. It's mons pubis, labia minora, clitoris, urethral opening, and the vestibule vagina. And this is like the opening of the vagina. It lists it all out for you there in figure 39.1. You will, most of it is, okay, with the transabdominal scan up top, you have a wider field of view. You can see more. However, you don't have as much detail as with a transvaginal ultrasound. You can't see as quite as far out with a transvaginal, but there's way more detail. So a lot of places they do both. So the transabdominal, or not a lot, some places will do both. I would like to go straight to that transvaginal. Unless, of course, you're dealing with like a 10-year-old. You're not going to do a transvaginal on 10-year-olds. Alright, the external genitalia in the female is known as the vulva or the pudendum, and it consists of all of these. The mons pubis is a pad of fatty tissue and thick skin that overlies the symphysis pubis and is covered by pubic hair after puberty. The labia are folds of skin at the opening of the vagina. You got the majora and the minora. Move down to bony pelvis. Anatomically, the pelvis is divided into two continuous compartments. You got the true and the false pelvises. And that is by an oblique plane that passes through the pelvic brim. And you can see that in figure 39 too. And that like little imaginary line kind of corresponds with the iliopectineal line. And so that divides the true from the false pelvis. The false pelvis is known as the greater or major pelvis, and that is above the brim. Whereas below is the true pelvis, and that is below, or the true pelvis, also known as the lesser or minor pelvis, is the area below the pelvic brim. Okay? Alright, the true pelvis is situated inferior to the caudal portion of the parietal peritoneum. So the parietal peritoneum, you guys know that's a part of the peritoneum up here, and so the caudal portion is down towards the feet. So at the bottom of it, below it, is where you're going to start getting this true pelvis. And it's considered the pelvic cavity, and that true pelvis is considered like the true pelvic cavity. So know that the false pelvis is up top, true pelvis is underneath. Alright, so flip the page. Down at the bottom of that paragraph, it says the pelvic floor is formed by the levator ani and coccygeus muscles and is known as the pelvic diaphragm. I want you to know what muscles make up the pelvic diaphragm, which is also known as the pelvic floor. Okay? So know the levator ani muscles, and the levator ani muscles are actually 3 muscles, and we'll go over those in a second, and then the coccygeus. And then the area below the pelvic floor is called the perineum. Alright? The area below pelvic floor is perineum.
The lower margin of the pelvic cavity.
Alright, box 39.2 is a very good box for you guys to look at for the muscles. It just summarizes all that up for you. Alright, let's move over to muscles of the false pelvis. And that includes the psoas major and iliacus muscles. So I want you to know that in the false pelvis, those are the muscles, the psoas major and the iliacus muscles. And know that they join to form the iliacus muscles. Not the iliacus muscles, the iliopsoas muscles. Alright, so it's like you take the iliacus and the psoas major muscles, and they join to form the iliopsoas muscles. Okay? So that's what you need to know about the false pelvis.
940 muscles.
941, under muscles of true pelvis. Highlight that first line, that first sentence, and then skip over to the next page and highlight that first sentence. And then put a star beside box 39-2, because you need to know that box. That summarizes all this muscle stuff for you. Alright, muscles of the true pelvis. The muscles found within the true pelvis. Oh wait, okay, so here's our little box right there. Is this on your homework page?
Oh, crap.
Area below pelvic floor is perineum.
Perineum.
And that's it. Alright. The muscles found within the true pelvis include the piriformis muscles. Oh, let's get that part. Okay. Muscles of the true pelvis are the piriformis muscles, the obturator internus muscles, and muscles of the pelvic diaphragm. And then it goes over in that box, it tells you piriformis, that's the posterior lateral wall, obturator internus is the anterior lateral wall, and then the pelvic floor, again, is the levator ani and the coccygeus muscles. And that's the pelvic diaphragm, or pelvic floor, same thing. Alright, so let's move down a few sentences, down where it says like figure 39-8 in the middle of that paragraph. After that, it says the levator ani is a group of 3 muscles that extend across the pelvic floor like a hammock. So they extend across the pelvic floor like a hammock. And this group of muscles consists of the pubococcygeus muscles, iliococcygeus muscles, and the puborectalis muscles. So underline that, highlight that. You need to know the 3 muscles that make up the levator ani muscle group. Okay?
And the muscles of the true pelvis, like
Of the
past the middle, starting in levator.
Yeah, it's right after where it says figure 39-8 in the paragraph. It's the next 2 sentences. Alright, bladder and ureters. Alright, the urinary bladder is located in the anterior portion of the pelvic cavity. So it goes bladder, uterus, rectum. Let's see, the function of the bladder is to collect and store urine until it empties through the urethra. You guys kind of already know that, though. That's just something you already know. Let's see, the ureters are 2 tubes. Turn the page on 942. That first line in the first full paragraph. The ureters are 2 tubes that carry urine from the kidneys to the urinary bladder, and they enter the bladder at the trigone. So the ureters enter the bladder at the trigone. Alright, skip the next sentence. The ureters are not normally visualized sonographically unless obstructed, or unless they have urine in them, like we saw, I think it was yours, someone like actively filling up and urine was going through the ureters and we can actually see the ureter that way. And it was just the distal ureter that we saw that way. Alright, so moving on to vagina. The vagina is a collapsed muscular tube that extends from the external genitalia to the cervix of the uterus. So the vagina goes all the way, but it stops at the cervix. It lies posterior to the urinary bladder and urethra, and you can see in figure 39-9, it goes urethra, that vagina, or vestibule of the vagina, and then anus. Those are the orifices, and in their order from anterior to posterior. It measures approximately 9 centimeters in length and is longest along its posterior wall because it lies slightly posteriorly, kind of goes towards the back. The posterior wall is actually what's longest. Alright, skip down to the next paragraph. The uterine cervix protrudes into the upper portion of the vaginal canal, forming 4 arch-like recesses called fornices. So know about these fornices. And you can see it, the uterus actually indenting down, or not, but like the cervix, like indenting down into the cervix. Okay, on the next page, figure 3910 is a good one. It actually labels the fornix too. But the cervix actually protrudes down into the vagina, and there's like the little walls that come up, the like little spaces beside it. Those are called the fornixes, or fornices. Okay, so turn back to 349 under normal anatomy of the uterus. Again, you guys already know this. The uterus and vagina are derived from the embryonic Mullerian or paramesonephric duct. Same thing. The uterus is pear-shaped. Here's our picture. The uterus is pear-shaped and is the largest organ in the female pelvis whenever the bladder is empty. But of course, if you've got a really full bladder, it's going to be the biggest. The average menarcheal uterus, which is a uterus once someone has reached puberty, it measures approximately 6 to 8 centimeters in length and 3 to 5 centimeters in the AP and transverse dimensions. So that's like, if this is our uterus and we're measuring, this is like our AP, and this is our length. Okay? And then in transverse, we measure this way. That's our temperature. Let's see, the size of the uterus varies with age and parity. So if you guys were scanning someone that doesn't have any children, their uterus is going to be, it's going to look smaller than someone that has like 3 children. So the uterus varies in it with its size, with age and parity, or how many children they've had. The uterus consists of a fundus, body, and cervix. Put a little star beside that box 39.6. That kind of summarizes a lot of the uterus, and that's a lot of this up here. But again, the fundus is the widest and most superior portion of the uterus. That's up top. That's this part up here. We said the bladder has to cap the fundus. This is the fundus. At the lateral borders of the fundus are the cornua. You have to know what the cornua is, or are. And you can kind of see in that figure 3911, where it's like the uterus up there, the fundus, they kind of come out a little bit where the fallopian tubes enter. That's the cornua right there. That is, again, where the fallopian tubes enter the uterine cavity. The body, or corpus, lies between the fundus and the cervix and is the largest portion of the uterus. So though the fundus is the widest and the most superior, the body is actually the largest portion. And so it goes fundus, body, cervix, and then vagina. All right, over next paragraph. Skip the first 2 sentences. The surface of the cervix is divided into an exocervix. So again, this is talking about how the cervix protrudes to the vaginal canal, and it has the little recesses, the little corners. Those are called fornices, and the cervix is kind of divided or into an exocervix and an endocervix. The exocervix, is squamous epithelial, continuous with the vagina, so it's like on its way exiting. So think of like the baby is coming out, it's gonna hit the endocervix, which is more internal. The exocervix is closer to the exit. The cervix is constricted at its upper end by the internal os. You guys need to know about the internal os. You're going to hear it all the time whenever you guys start scanning in OB, because you have to check the internal os, because that's what is actually going to dilate. And so you want to check what the position of the baby is according to the internal os. You want to check to make sure that the placenta is not covering the internal os. So you have to know about the internal os. And that is the inner portion, that's the inner constriction of the cervix. Like this is your cervix right here, and then vagina's here, and then uterus is up here. This is going to be your internal os, and it opens and dilates. And that's where babies and all that come out. And all that. Alright, and then the external os is the closest to the exit, just like exocervix is closest to the exit. That's at the bottom portion. And here it's in figure 39.1, they're calling it ecto in the picture. Same thing as exo, and you see the endocervix is closer to the inside, ecto is closer to the exit. Alright, the isthmus is the outer transition point between the body of the uterus and the cervix. So where cervix becomes body, that little transition point is called the isthmus. And this is the point where the uterus bends either anteriorly or posteriorly, depending on if you have an anteverted or a retroverted uterus. Or aniflex, retroflex. Alright, the layers, the uterine wall consists of 3 histologic layers. Histologic just means like what it looks like under the microscope, like what the cells look like, all that. You got the serosa or the perimetrium, same thing. That's the outer layer of the uterus. And then you have the myometrium, which is the middle layer, and that's the muscle layer. That's our thickest layer too. And it's composed of thick, smooth muscle. And the endometrium, that's that inner mucus membrane. It's the glandular portion of the uterine body. That's the actual inside. That's the inner layer. So you got serosa or perimetrium, which is the outer. Myometrium is the middle, and then endometrium is the inner layers of the uterine wall. Okay. Again, the muscle layer, which is the myometrium, that is the thickest layer. All right, moving on to endometrium. The endometrium consists primarily of 2 layers: the superficial functional layer, which is the zona functionalis, and the deep basal layer, which is the zona basalis. I always remembered, I had to think about it like the deep basal layer, that's like the basal, the base, and so I would think, well, that's the base, it's going to be on the bottom, so the functional layer is going to be up top, and that's the superficial layer. The functional layer is actually what is shed with menses. So your endometrium is kind of subdivided into a zona basalis and a zona functionalis, or your deep layer and your functional layer, or your superficial layer. And that superficial layer is what actually gets passed and gets shed. Okay? Okay, so here's a picture. The serosa is very thin. It's just like this outer layer here, this outer lining. And then you got all your myometrium. All this is myometrium. And then you got your endometrium. Okay? Alright. Okay, well this is, I said I'm showing everything with a transvaginal image, and so this is transvaginal, this is transabdominal. So here, just the layer of this is serosa or perimetrium. This is all myometrium here, and then this is all endometrium right there. Here's our vaginal canal. Okay.
The functional layer.
Yeah, uterine ligament. Let's see let's go back to after the menses. The basal layer is a thin layer that regenerates new endometrium after menses. So the functional layer thickens up and sheds with each, but it's that basal layer, that base, that will cause the functional layer to become thickened. So it actually like feeds it and causes it to regenerate and then pass. The endometrium changes dynamically in response to the cyclic hormonal, just depending on where you are in your cycle, the endometrium gets thickened and then it sheds and becomes real thin, and then it thickens again and then it sheds. So depending on where you are in your cycle and the hormones that are getting excreted. Alright, so put a little star beside box 39.9 and 39.10, and also 39.11. That is summarized. These boxes summarize a lot of what's in the written text. Alright, moving on to uterine ligament. The uterus is supported in its midline position by paired broad ligaments, round ligaments, uterosacral ligaments, and cardinal ligaments. And we'll go over each one of those. The broad ligament is a double fold peritoneum that drapes over the fallopian tubes, uterus, and ovaries. And the broad ligament is further, like the part of it that drapes over the fallopian tubes is called the mesosalpine. and that's there in bold. And then the part that kind of drapes over the ovary is called the mesovarium. And so, and that's the posterior portion of the broad ligament that drapes over the ovary, or ovary. All right, the round ligaments are fibrous cords that occur in front of and below the fallopian tubes between the layers of broad ligaments. So they kind of go down in between the broad ligaments, and they and it actually helps hold the uterus in that forward position. But when someone has had, multiple children, that ligament starts loosening up, and then the uterus can become retroverted or retroflexed and kind of loosen and fall back. The cervix is the only portion of the uterus that is firmly supported. So the uterus itself is not fully there at all times. It's not going to move any which way. Or it's not like that. It can vary where it is. But the cervix is the one part of the uterus that is firmly planted in its position. And it is fixed in position by the cardinal and uterosacral ligaments. You need to know that. Cardinal and uterosacral ligaments firmly support the cervix and keeps it right there. And anybody needs to go to that, y'all need to go. Does anybody want to stay for like tutoring? Because for tutoring, we're just going to finish up this chapter. And then I'm going to put all of this on, we're missing 4 pages, so I'll put all of this on the computer. But really, seriously, it's almost everything. I think I highlighted all of this. Yeah.
It's everything else?
It's everything, yeah, because, just, take it home and do it like a homework assignment.